Chest tube thoracostomy by Senior Clerk Alisa Alcarat. Chest tube thoracostomy is an essential skill of a physician to deal with certain pleural diseases. It is a procedure where a hollow tube is inserted between the ribs into the pleural space to drain air, blood, chyle, and pus, and any other fluid. It is indicated in patients having pneumothorax, hemothorax, hemopneumothorax, empyema, and subcutaneous emphysema, and in a patient who has sustained chest wall trauma requiring ventilator support or general anesthesia. In preparation for the procedure, we obtained informed consent. For the materials, we will be needing the following: cut-down set, sterile gown, sterile surgical gloves, glass bottle system with underwater seal, chest tube, povidone iodine, sterile sponges, silk O with curved cutting needle, vaselinized gauze, and plaster. For the procedure, if it is possible, have the patient assume a semi-upright position with the arm placed above the head. The ideal placement of the chest tube is within the triangle of safety. This is the anatomical region bordered by the pectoralis major and latissimus dorsi laterally, by the base of the axilla superiorly, and by the horizontal level of the nipple inferiorly. Identify the fourth or fifth intercostal space at the anterior axillary line at the site of injury. Identify the sternal angle. The structure adjacent to it is the second rib and their intercostal space. From this location, move downward to locate the fourth or fifth intercostal space. Prep the skin with povidone iodine using forceps and cotton balls in a wider area in case there is a need to go further in the insertion. This should be done in an outward concentric motion. Drape the area with 4 towels and not with a single fenestrated sheet. Place the first towel on the surgeon's side, cephalad, caudad, and the side opposite that of the surgeon. Use towel clamps to secure the drapes. Infiltrate the skin using local anesthetic and block the intercostal nerve branches. Make a 2.5 to 3 cm skin incision parallel to the axis of the ribs and into the subcutaneous tissue. Measure how far the chest tube is to be advanced after placement. The tip of the tube should be placed at the apex of the lung. Insert a curved Kelly clamp to separate or cut the tissues in creating a tunnel or a track in the direction of the tube insertion. Direct the track posteriorly, cephalad, and immediately so that the tube lies posteriorly in the paravertebral gutter. Continue developing the track into the pleura. Remove the clamp and explore the track with a gloved finger from time to time. Further enlarge the opening in pleura using a large Kelly clamp. Grasp the tip of the tube with a curved Kelly clamp wherein the long axis of the tube is parallel to the long axis of the clamp. Make sure to clamp the distal end of the tube if hemothorax is suspected. Insert the tube to the chest with a large Kelly clamp as a guide. Remove the clamp when the tube has reached the desired position in the chest. Palpate superiorly and inferiorly to ensure that the tube has entered the chest. Suture the chest tube to the skin with a silk O by placing a horizontal mattress. Cut the needle and throw it in the sharps to avoid puncture wounds. Tie the suture in place. Wrap the remaining sutures around the chest tube to secure it. Make at least 4 loops to secure it in place. Push the suture down and secure with a knot. Before unclamping the distal end of the tube, connect the tube to the underwater sealed chest drainage system. Make additional stitches for skin closure. Dress the tube with a vaselinized gauze around it and push up against the chest to ensure no air leak. Cover the tube side with 4x4 sterile gauze with a slit. Remove the drapings and secure with a plaster. Remember to obtain a post-tube insertion chest x-ray to check the position of the tube.